Welcome to the webcast, Sclerotherapy in the Treatment of Venous Diseases, a comprehensive review of best practices while using compounded and FDA-approved agents. This program is sponsored by the North American Center for Continuing Medical Education and is supported by an educational grant from AngioDynamics, Incorporated. My name is Dr. Gilly Manavali, and I'm going to be your presenter today, along with two other presenters, Ms. Carla Palmer, the Director of Hyman Phelps and McNamara, PC, and Dr. Nick Morrison, who's President of the International Union of Phlebology and co-founder and medical director of the Morrison Vein Institute. So these are my disclosures as relevant for this talk. I am on the Speakers Bureau of MERS, Inc., the maker of, the distributor of Sclera in the United States. And I'm going to be talking today about the off-label use of both the Sclera and Sotradecol for the treatment of chronic venous insufficiency and cosmetic spider veins. So here's some of the learning objectives I'm going to focus on. And my goal of really speaking with you today is to provide some overview on these points. The first point is to identify when to use sclerotherapy in a patient with varicose veins or related chronic venous insufficiency. And secondly, we'd like to identify the economic, safety, and legal factors when choosing a compounding sclerosant versus an FDA-approved sclerosant, and that'll be mostly Ms. Palmer. And then also going to discuss the risk factors associated with compounding sclerosants, which will be mostly Dr. Morrison. So today, my topic will really center around three things. One is a basic an overview of the basic venous anatomy, and secondly, we'll talk about a couple clinical correlations that you might see in practice, and then thirdly, we're going to speak a little bit about best practices when injecting for sclerotherapy. So the treatment approach for sclerotherapy really should follow a pre-designated pathway. And firstly, you want to make sure that if there's any type of reflux existing in the saphenous system or the higher-up system on the leg, the venous system, that high pressure is eliminated first. And that's done by identifying reflux and then using, nowadays, either conventional endothermal technologies such as the 1320 nanometer laser or radiofrequency and or ambulatory phlebectomy to shut off the pressure in the saphenous system. Additionally, we can inject with sclerotherapy agents in a duplex-guided manner. But once this is accomplished and we've identified there's no more flow in this saphenous system, in the refluxing saphenous system, we would go on to treat the reticular veins, which are those blue veins, kind of flat, sometimes prominent or bulging, with the refluxing site around the refluxing sites, because those are associated with the spider veins. So the reticular veins will be treated along with any associated telangiectasias in that same area, typically on the same day. Now you can also use laser to treat the smaller telangiectasias if you desire. We typically tell patients it's 3 to 5 treatments per area, and it's really variable, but we want to make sure we have enough treatments to cover and get a good result. And we don't typically repeat the treatments until 3 to 6 weeks, so that's our duration of time, because we want to give the best chance for the damaged veins to be resorbed and disappear. We typically treat from a proximal to distal fashion, and we will treat the entire length of the vein at one session. So as I mentioned, we will treat the associated reticular veins and the spider veins or telangiectatic matting veins all in the same session. And also we'll touch on treating with foam sclerotherapy. So conventionally you can use liquid sclerotherapy or foam, which is mixing with air. So we'll talk a little bit about both of those. There's some common patterns we're going to talk about with venous disease. It's important when you see the patient for the first time and you've eliminated the reflux and you're going to start treating with spider veins to know kind of where to treat and what areas could be triggered by certain refluxing veins in the area. So really when we're worried about the superficial veins of the legs, we're really talking about the saphenous system. And the saphenous system can consist of several different branches or truncal veins and then also the saphenous vein. So here you'll see on the left diagram the great saphenous vein, which is the biggest of the superficial saphenous veins in the legs. and this comes down the medial aspect of the leg, starting at the medial malleolar or ankle area and then terminating all the way up in the groin into the femoral at the saphenofemoral junction. Along with that, on the anterior leg, you can see associated small reticular beds of veins, bluish beds, specifically on the outside of the leg. We call the anterior lateral venous system. And we'll show some pictures of that, and the significance of that is it's very common to see that in younger women in the absence of reflux. So the lateral subdermic venous system is another name for it. And then on the right side of the diagram, you'll see this small or short saphenous vein has previously been called the lesser saphenous vein. And that one is, again, another part of the superficial saphenous system that extends from the Achilles area down and then going up through the gastrocnemius muscles and then dumping in variable sites into the popliteal vein, or sometimes directly into a connecting vein that goes to the saphenous. So when we talk about saphenous reflux, those are the things we're talking about, and that's what we need to eliminate before we think about treating spider veins. The significance of spider veins in these areas is kind of a giveaway as to whether those areas are refluxing. So Dr. Weiss, Margaret and Bob Weiss in their textbook call these zones of influence, and by that they mean that, for example, in the medial part of the leg, if you see spider veins or bulging veins in that area, you've really got to immediately think about, is there reflux in that area? And you want to get that checked with duplex and verified. If you see spider veins or bulging veins in the posterior aspect of the calf, that could signify that there is some reflux in the short saphenous or lesser saphenous vein on the back of the calf, and that would need to be identified and treated before moving on to sclerotherapy. And the lateral venous system is a little unique. That system is not necessarily dependent on the saphenous system. So you can have reflux in the saphenous system and have the system present, or you can have no reflux and still have the system present. The lateral venous system is one of those vestigial systems that just kind of exists, and if there's spider veins that are obvious in these areas, they can be treated without necessarily having to interrogate the entire saphenous system. And again, this is the lateral system is what you'll see very commonly in younger women in their 30s to 40s, and they're very distressing cosmetically. So we'll focus a little bit more on the great saphenous vein anatomy, the medial aspect of the leg. You can see here again the great saphenous vein courses up the middle part of the leg, terminating in at the saphenofemoral junction. And there are numerous branches that come off this. The anterior lateral branch coming across the thigh, then there's the anterior tributary veins that come across the thigh. And these veins can be, as a result of increased pressure, these veins can be bulging and would need to be dealt with as well. So all that would be determined in your clinical examination and any subsequent duplex examination. Some other giveaways here when we're talking about leg anatomy are, again, the presence of these bulging veins within certain areas. So these are some sample patients that you can see what we're talking about. So these pictures depict bulging veins in the middle part of the leg, specifically in the ankle or malleolar area where the pressure is the highest. So if you can imagine having some refluxing at the saphenofemoral junction up high in the inguinal area, that pressure transmits down below, and you start to get bulging in the ankle and the middle part of the calf, and that's what you see here. These signs that you see on patients are almost a dead giveaway that the saphenous system is refluxing and needs to be addressed. So you really want to examine carefully. This is another example. These are all pictures from that were provided by the Weisses, and they will show you that you've got some saphenous reflux in this area because you've got a lot of long-standing pressure. And that pressure is what's causing all these little spider veins to form. And if you look above that, there's some bulging veins that are causing that. Now, if this lasts for a long time, you can get breakdown of the skin and indeed get some ulceration in these areas. And that's what you're beginning to see in that image on your right side. On your left side. These are all signs of GSV or saphenous reflux, and this is really a calling card that your patient should be sent for duplex evaluation before doing any injections. So this is an example of a patient who has spider veins around the ankles as a result of reflux. The reflux was treated and those veins went away without having to do anything additional. Now, this doesn't always happen. It kind of depends on the duration of the presence of veins in these areas. But if they've been around for a relatively short amount of time and the reflux is treated and the pressure is eliminated, these spider veins will go away. If they don't, then they can be safely treated with sclerotherapy, and they usually respond very well. This is just another example showing some lower leg venous anatomy. Here you have your great saphenous vein and the anterior accessory saphenous vein. And when you're looking at patients and you see bulging in these areas, this is what you really need to think about. So let's move on to the lesser or short saphenous vein, which is in the posterior calf. And you look at the diagram and you can see that we discussed the saphenous, short saphenous, lesser saphenous vein coursing up through the gastrocnemius muscles, terminating in the popliteal area or a little bit above. And when you see veins bulging in this area, this is the vein you have to worry about. There's also a connecting vein, which is called the intersaphenous vein now, but previously called the vena Giacomini, that can go from the short saphenous, lesser saphenous vein all the way around the posterior thigh to the great saphenous vein. The significance of that is it can transmit pressure from a refluxing great saphenous system down to the posterior aspect of the leg, behind the leg, and then indeed all the way into the lesser saphenous vein. So these veins need to be integrated if they look like they're bulging or if there's symptoms. These are some clinical images that you might see in your office comparing just someone who walks in having some pain in the back of their calf, and you look, and in this case, though, the bulging and the spider veins are on the lateral part of the ankle, not the middle part. And then you've got bulging in the posterior calf along with some spider veins. These are all signs that the short saphenous vein needs to be evaluated for reflux. So let's move on to the subdermic lateral system. This is in the lateral thigh of women, as we showed you. Prominently in this demographic, it occurs in the lateral knee, kind of in an X-like pattern, and it can extend down to the posterior and anterior thigh. It can also go down lateral to the posterior calf. When you look in anatomic dissections, it can show that there are small perforating veins, or veins that transmit pressure between the deep and superficial venous system, that can occur near the lateral knee that can cause some of this. But the important thing is that this is not typically related to saphenous reflux. These are some examples of this system out here, the lateral subdermal venous plexus. And if you see these type of this arrangement of veins and no other worries about saphenous reflux, you can go ahead and treat these with sclerotherapy, remembering to treat the blue reticular veins at the same time as these spider veins are treated, and patients will get a very good response. This is another example from the Weisses showing classic lateral venous lateral system spider veins and a reticular vein. So once you get rid of the reflux, we typically mentioned we use endothermal methods, and now there are new methods available. But your legs will feel, the patient's legs typically feel a lot better, and we try to eliminate the bulging at the same time. So this is an example of a patient that's had great saphenous reflux as well as some bulging veins in the anterior and medial calf. So they were treated with the 1320 nanometer laser to seal off the refluxing great saphenous vein, and then concurrently were treated with ambulatory phlebectomy, which is a procedure to hook and remove the bulging veins. And you can see the after image in the right that their legs look a lot better, and more importantly, they feel a lot better. So in this scenario, when you have residual spider veins left, it's a good time to start treating for cosmetic purposes. Here's another example showing some reduction of the swelling. You can see some of the sock lines have gotten better because the venous flow is normalized, and patients feel much better, and the venous return is greatly improved back to the heart, and swelling gets better. So we'll go back to this slide. So we've taken care of the reflux. We've started looking at treating some of the bulging veins with phlebectomy. We've done that. We've now looking at treating some of the spider veins. So we're going to talk about how to do that. I think one of the key overriding concepts when you talk about injecting sclerosants into spider veins is how to manage the concentration and the quality of the injectable sclerosing agent to best treat the spider vein without overwhelming and using a higher concentration that you need. So our goal is to deliver the minimum volume and concentration of sclerosant that will cause irreversible damage to the endothelium of the abnormal vessel. And this is a theme that you'll hear discussed often, and this is one that's very important And this comes with some experience, but also with evaluation of the clinical size of the veins, as we'll show you. Typically, the vessel size is the best predictor of the concentration needed. So by looking at engaging the vessel size, you can get an idea of where your starting point would be. But there's no simple formula. Sometimes you'll have to vary the concentration, but always try to start at the lowest possible concentration. Why is that? Because high concentrations will rarely speed up resolution of the vein, but they can cause increasing complications, such as hyperpigmentation, ulceration, and even some telangiectatic matting or new vessel formation. So what is our suggested concentration? So here we're showing the vessel size and in a table, and then we're proposing some sclerosant concentrations for these vessels. And then there's acronyms or abbreviations for the type of agents that we're using. So for example, if we're treating a vessel that's less than 1 millimeter in size, we would consider using some of these agents, non-foam, so it would be hypertonic saline, Polidocanol at 0.5%, Subdermic or sodium tetradecyl sulfate, at 0.2%, or chromatic glycerin at 72%. And then you go up from there just based on what you see here at the table. And these are all starting points. And the goal, again, is to try to use the minimum concentration necessary. How do you determine the vessel size? Well, there have been some really nifty gauges developed over the years. Dr. David Duffy, who's an icon in the phlebotomy field and dermatology field, had developed a guide, recognizing this really early on, developed a guide that you see here. And this guide allows you to just place it on the skin next to the veins, and you can get an idea of what size of veins you're dealing with. So this is an example. So these are some relatively small veins, 0.1 to 0.15 to 0.2 millimeters, and we know, we know that by looking at the gauge. So consequently, we can determine the exact size of the sclerosant to start with. Here's another example showing some spider veins and a needle. The reason why it's important to determine the spider vein size also is because that will determine what needle you might use. The needle size relates to the discomfort of the patient. So obviously we want to use the smallest needle size possible. Here illustrated is a 30-gauge half-inch needle. This is a very appropriate size needle to use for sclerotherapy. You can also use a 32-gauge size needle if the veins are much smaller. But you can imagine if the veins get smaller than the needle size, then you're going to have a problem getting the needle into the vein. And that's where you might consider using lasers or some other source of energy-based device to treat spider veins. That's outside the scope of this discussion, but this gives you a good example of when you might do that. Here's some more spider veins that you can see and gauge the size. And again, these can occur on lighter skin types or darker skin types. These are some smaller veins, probably 0.1 millimeters to 0.15, and these can be very difficult to cannulate or get into with a needle. So if you can't get into the vein, then you really don't have any options for sclerotherapy. So we typically start with 30-gauge half-inch, and then we may go to 32-gauge, and 32-gauge may work in this one. If not, then you can consider other methods. So we use these sclerosing agents, and it's always also good to have an idea of how much of the sclerosing agent you can use at any given time. This is a table showing the maximum dosage of the most commonly used agents. Again, there's the abbreviations for sodium tetradecyl sulfate, Polidocanol, chromatic glycerin, and hypertonic saline. And the maximum dosage that you may consider using in your patients. So for example, for STS, we would use 10%, we call it kind of like the 10 rule, the rule of 10. So 10 cc's of 3%. We rarely use 3%, if ever, for spider veins. So our more typical concentrations of 0.1 to 0.2% equate to about 300 cc's. So you have a lot of safety factor when doing these treatments. Keep in mind that the average treatment session is typically 20 to 30 minutes, and so you're not going to, you need to factor that in as well into your treatment volumes. You don't want to go over these, or you may risk causing some complications. Polidocanol, 10 cc's of 1%. Again, we rarely use 1% treating spider veins. We'd be more likely to use 0.25 or 0.5%, so you can adjust accordingly. chromated glycerin, 10 cc's per session, and then hypertonic saline, it varies. It is physiologic, so you have a little bit more of a buffer there, but some reports in literature have talked about using 20 cc's for this. Now, hypertonic saline of these solutions is the one that's most likely to sting and cause some burning. And so this is, although it's the most popular sclerosing agent, it may be a challenging one to start with when you're learning on patients because it can cause some stinging. So immediately after the treatment, you're going to see the vessel turn angry, a little red, a little raised. You might develop some wheals around the vessel, and you could imagine looking at this, that the injecting agent has been put in and damaged the vessel wall, and you have some resulting damage there. And then over time, that vessel will fade away, sometimes causing some hyperpigmentation, and probably about 11 to 15% of the time, and that would need to be managed, but usually passage of time takes care of that. These are just some clinical examples showing that lateral system being treated effectively, and a nice improvement there. And then the posterior calf, these collections of spider veins with a nice improvement after several treatments there. So in summary, just some overriding themes to fall back on one last time. We want to make sure that the high pressure reflux is eliminated first. We want to make sure that if it exists, we want to make sure that we use the minimum volume and concentration of these sclerosants to cause damage and treatment that way rather than starting at a high concentration. And then we want to think about treating the reticular or the blue veins first because they're actually feeding the smaller spider veins, and then go with the spider veins. And doing that in the same session is ideal. So I wanted to thank you for your attention during this session. I'm now going to turn things over to Ms. Carla Palmer to begin her presentation. She's going to focus on the second learning objective. So thank you very much for your attention.
Thank you, Dr. Munivalli. As mentioned, I'll be focusing on the second learning objective of today's presentation, and that learning objective is as follows. Identify the economic, safety, and legal factors when choosing a compounded sclerosant versus an FDA-approved sclerosant. I'd also like to state that we have a few disclaimers I'd like to make here, and those are the facts and opinions rendered in this presentation are those of the author, that's Carla Palmer only. And by making this presentation, I am neither giving legal or otherwise rendering legal advice, and this presentation is made for informational and educational purposes only. And publication of this presentation or your review of these slides does not create an attorney-client relationship. So on to the first part of my presentation, I would like to provide a general background concerning the regulation of compounding pharmacies and what has recently been created, outsourcing facilities. There are two types of compounding pharmacies that exist in the United States, and one is the traditional compounding pharmacy, and they are regulated under what is considered Section 503A of the Federal Food, Drug, and Cosmetic Act. And these are pharmacies that you typically see in states that are regulated under state pharmacy laws. They are held to certain standards set forth in the United States Pharmacopoeia concerning sterile and non-sterile compounding of products. But under federal law, to be a traditional compounding pharmacy under Section 503A, and compounding pharmacies may compound sclerosants and other products, but to do so, there are certain obligations and regulations and statutes that apply. Under federal law, they must compound pursuant to a prescription or order for what is considered an individually identified patient. That means there's no office stock compounding permitted for physicians. There's no office use compounding for physicians that's permitted under Section 503A of the Federal Food, Drug, and Cosmetic Act. To the extent that a compounder engages in appropriate compounding under Section 503A, that compounder is exempt from certain new drug, directions for use, and good manufacturing practice federal requirements. So it must be for an individually identified patient pursuant to a prescription or order, and 503A pharmacies are permitted to compound if they follow those guidelines. There's a new type of outsourcing facility that was created pursuant to Section 503B of the Federal Food, Drug, and Cosmetic Act, and that entity was created in 2013. They are a quasi-drug manufacturer. They must compound a sterile product. They may also compound for office use or office stock. That means they don't need a prescription. They are exempt from certain of FDA's requirements, but not all of them. That is set forth on the slide. So I'd like to give a brief summary for you now that we've discussed the two different types of compounders. I'd like to give which you may see in your practice, I'd like to give you a brief summary of the regulation of compounding pharmacies and outsourcing facilities. Starting in 2013, the federal government became significantly more interested in compounding, and that is because there was an entity up in Massachusetts called the New England Compounding Center that really changed the game for compounding pharmacies and created the outsourcing facility rubric or caused Congress to create that at the end of the day. In Massachusetts, a compounding pharmacy shipped a contaminated epidural called methylprednisone. It shipped this nationwide. The methylprednisone epidural was contaminated with a fungus. It resulted in widespread meningitis outbreak. More than 800 people got sick. More than 64 people died. There's been at least 400 individual lawsuits filed. There's been an indictment of over 14 individuals, and in March 22nd, 2017, the co-owner of it, NECC, New England Compounding, was convicted of various crimes. He was cleared of murder, but he was convicted of racketeering, multiple counts of fraud, and he's awaiting sentencing. So the issue for all compounders who compound pursuant to either 503A and 503B, what they consider is, how did this happen? How did NECC, did their treatment of compounded products and their distribution and dispensing of compounded products, how did this happen and cause so many people to get sick? Looking back on that, FDA inspected NECC, the state inspected NECC. In the spring of 2013, Congress investigated this incident and FDA's role in it. Congress subpoenaed FDA, and FDA testified that the reason why this happened is because there was indeed a certain lax enforcement against compounding pharmacies in the years from 2000 to 2012, because FDA didn't have enough power over them, and there was conflicting case law concerning FDA's ability to regulate what compounders did. As a result of this, in late 2013, Congress created or enacted the Drug Quality and Security Act, Title I, which is called the Compounding Quality Act, and that created outsourcing facilities. It reinvigorated Section 503A. It removed certain unconstitutional advertising provisions from that statute, and FDA has been on a regulatory tear, so to speak, because of its, quote, miss with respect to NECC. So since 2012, 2013, the next slide is increased FDA inspections post-NECC. FDA started inspecting compounding pharmacies with increased frequency. It has inspected hundreds of compounding pharmacies since 2013, and it is still inspecting at an incredibly high pace compared to how it acted pre-NECC. Since 2013, FDA has, with respect to their current inspection statistics, it has inspected at least 403 compounders. 285 of those inspected are Section 503A pharmacies. 114 are Section 503B outsourcing facilities. 2 are physicians. 3 are makers of allergenic extracts, and FDA has also inspected several laboratories. More statistics concerning FDA inspections are continued on the next slide. Most notably, these inspections are the work of 331 FDA investigators across the nation. This equals 19.3 man-years on 503A pharmacies and 10.4 man-years on 503B facilities. Please note that FDA is not slowing down on its inspections, and pharmacies and outsourcing facilities must be extremely careful concerning their compounding, distributing, and dispensing of prescription drugs, because FDA is scrutinizing what the pharmacies compound and how they compound with more vigilance than at any other time in history. With respect to inspection statistics, FDA has also issued warning letters to almost 100 traditional pharmacies and over 50 Section 503B outsourcing facilities. A warning letter is correspondence that notifies the regulated industry about violations that FDA has documented, and these are considered issues of regulatory significance. More of these are issued every week. With respect to, going on to the next slide, current FDA inspection statistics, there are about 63 Section 503B outsourcing facilities across the United States. They are subject to mandatory risk-based inspections. Most have had 2 to 4 inspections. And then there are 42 outsourcing facilities that have basically found FDA's processes so rigorous that they have dropped their 503B registration. Outsourcing facilities have to comply with FDA's current good manufacturing practices for pharmaceutical manufacturers. So to the extent that they find it too difficult to act as a manufacturer, those facilities have dropped their registrations. Most notably, for the physician who is seeking to purchase compounded sclerosants or other compounds from pharmacies, you should note what the most similar observations are from across pharmacy inspections by FDA. Most of the inspections by FDA find very similar observations, and most deal with the fact that compounding pharmacies don't have adequate aseptic processing areas. Their systems for cleaning and disinfecting are inappropriate, and the procedures designed to prevent contamination are inappropriate. Continuing on, for outsourcing facilities, very similar types of observations have been made by FDA. So FDA has found that notwithstanding 503A and 503B and the federal creation of ways to do compounding, their rigorous monitoring of outsourcing facilities and 503A pharmacies has shown there are certain issues with respect to the environmental conditions of these compounders and their aseptic processing areas and their ability to test and release drug product for distribution appropriately. It's been lacking. So with respect to, going to the next slide, what outsourcing facilities and 503A compounders, what you should consider when determining whether or not to purchase compounds from either. To ensure the safety of a compounded product, consider requesting an unredacted copy of any FDA observations from an FDA inspection. These are called an FDA Form 483. Request an unredacted copy of any FDA warning letter, we discussed these a little bit earlier, that any compounder or outsourcing facility has received. And you also would like to request the facility's responsive documents to these government communications, if any. It would be prudent to review all this before you determine whether or not this pharmacy is an appropriate source of a sclerosant for you. Also ask the facility about recalls, state actions, any prohibitions or restrictions on a state license, any board actions, or any referrals between the federal government and the state concerning their compounded products. So state and FDA are communicating more and more about inappropriate pharmacy conduct within their jurisdictions, their respective jurisdictions, and there's a lot more federal and state communication between the two concerning problems to avoid what happened in Massachusetts with respect to NECC. There will be no more finger pointing between the state and the federal government concerning who's at fault. They're talking and they are determining the most appropriate course of action with respect to compounding pharmacies and outsourcing facilities that just don't seem to be able to get it right. So on to the next slide. FDA has taken certain steps to regulate more actively compounding pharmacies since the NECC disaster. And one of those matters that it's undertaken is to draft a memorandum of understanding between the states and the federal government, the FDA, to limit the amount of compounds that can be distributed or dispensed interstate. So you can go into a pharmacy and pick up a compounded sclerosant or another type of compound, but there will be limits eventually on the amount of product that a certain or any particular pharmacy can ship interstate. Pursuant to the federal statute, it will be 5% if the federal government and the state doesn't enter into a memorandum of understanding governing this. The current MOU that has been drafted by FDA and circulated places a 30% limit on interstate shipments. This is to prevent NECC from reoccurring. The federal government believes that a lot of the issue with NECC was the ability for that pharmacy to ship the product throughout the United States in significant volumes without the appropriate attention paid to the testing of those products. Notwithstanding the concern of the agency and of Congress, FDA has received greater than 3,000 comments on the draft Memorandum of Understanding. There are significant state and industry concerns reflected in these comments, and the limits on interstate shipment and the effect on patient care that such limits may cause. And there's also a significant legal action if FDA finalizes this guidance without addressing the concerns. Notwithstanding, moving on to the next slide, there's also, this slide describes the prescription requirements set forth in Section 503A concerning obtaining a prescription for an individually identified patient. It's pretty self-explanatory on the slide. In late December 2016, the FDA provided final guidance on the prescription requirement. The prescription just needs to be clear. There's no specific guidance set forth concerning what the prescription must say, other than it must be for an individually identified patient. Moving on to the next slide, the FDA has also issued guidance on what the limits on compounding essentially a copy of commercially available drug products. So this is pertinent to compounded Polidocanol and compounded Sclerosants because the essentially a copy draft guidance substantially and significantly limits what a compounder can do vis-a-vis a drug that is approved by the United States Food and Drug Administration. And set forth on this slide, it's just in draft right now. It was published in July 2016, and everybody's waiting for the final guidance to be issued. But for Section 503A, this slide sets forth essentially a copy draft guidance and just the basics of it, what is going to be considered by the agency to be essentially a copy. The next slide continues with that statement of what FDA considers to be essentially a copy under Section 503A, as does the following slide. There are 3 slides that address this. Next, the FDA has also published guidance on essentially a copy draft guidance for outsourcing facilities under Section 503B. And that was also published in 2016. the industry is awaiting FDA's issuance of final guidance on that. There have been numerous industry comments on both the 503A and the 503B draft guidance, and there is significant concerns on both the finished pharmaceutical manufacturing side and the compounded drug side concerning what constitutes essentially a copy and what does not. This is something that all prescribers will want to pay attention to once these are finalized, because notwithstanding any definitions, no prescriber wants to run afoul of these federal guidelines concerning what is and what is not a copy, and FDA intends to clarify its definitions of essentially a copy, likely during 2017. This concludes my presentation for today. But now Dr. Morrison will continue the conversation on sclerotherapy, describing the risk factors associated with compound sclerosants. Thank you very much.
Thank you, Ms. Palmer. As mentioned, I'll be focusing on the third learning objective, which is to describe the risk factors associated with compounded sclerosants. There is my disclosure slide. As you can see, it's fairly extensive. I want to start by first defining compounding, because it's important that we understand what we're saying. So the FDA statute states that the compounding is the combining, mixing, or altering of ingredients to create a customized medication for an individual patient. That's important, for an individual patient in response to a licensed practitioner's prescription. What that means is, if you obtained a medication from a compounder, it has to be as a result of a specific prescription for an individual patient. Now, the problem that we have experienced in the phlebologic field over the past few years with sclerosants is that there have been some very significant questions about the purity and accuracy of compounded sclerosants. That's a major problem. Some of us have experienced the use of compounded agents when FDA-approved agents weren't available, and we had some adverse events occur as a result of those compounded agents. And we didn't know for sure that we were getting what we thought we were getting. So why does the FDA care about this whole process? Well, in 2002, they sampled 29 products, and I'm not just talking about sclerosants. So these are all sorts of products from 12 different pharmacies that market through the internet, and these are compounding pharmacies. What they found that out of the 29 products, 9 products were not potent enough. 1 was contaminated, which represents fully a third of the products that they tested. By comparison, 1 to 2% of drugs from manufacturers fail to meet these FDA standards. So again, that points up the problem that we face with sclerosants is, do we know we're getting what we think we're getting? As far as concentrations, the reason the concentration is important, and this came from Mitch Goldman's book, the concentration of the sclerosing solution should match the size and type of vein treated to produce the minimal sclerosing effect. So you want to use the lowest concentration of sclerosant to achieve the result that you want to achieve without having side effects or adverse events occur. So if you choose the right sclerosant concentration and the type for example, very small telangiectasias, and the concentration is higher than you think it is based on the labeling, you can produce really significant excessive inflammation and even ulceration. If it's lower, of course, you're going to have ineffective sclerosants. You're not going to accomplish your goal. This is an interesting paper taken from several different sources, but particularly Jose Almeida reported this about a decade ago. He looked at Subdermic at the time. That was all it was FDA approved. Compared it to 3 other compounding pharmacies, so the product delivered by these other compounding pharmacies. And on the top of that slide, you can see for a sclerosant STS, sodium tetradecyl sulfate, what pH value should be, what the concentration should be, and whether there were solvents. So the pH should range between 7.8 and 8.1. The concentration, they chose 3%, and they allowed for 2.85 to 3.15, and no solvents. The Subdermic, the FDA-approved product, reached all of those goals. On the other hand, when you look at the product from CAPS, McGuff, and Kronos, you see that the concentration varied to a certain extent, although it met pretty much within the criteria. The problem was concentration. If I said concentration before, I meant pH. So looking at concentration, instead of 3%, you can be getting as low as 2.5% or nearly 3.5% of concentration. And there were solvents in all of the products. So this is another paper that came from Bob Weiss, published in 2011. He looked at Polidocanol. So by now, there's an FDA-approved Polidocanol. And he took 6 samples of 1% Polidocanol from 4 compounding pharmacies and evaluated them for the concentration and identification of impurities. Results showed that the range was from 1% all the way up to 3%. So if you choose 1% to treat telangiectasia and actually you're using 3%, you can see that your side effect profile is going to go way up. Analysis also showed impurities in all 6 of those samples. So the conclusion was the compounded solutions did not deliver the claimed concentration 5 out of 6 times, and the inconsistency really poses a risk to the patient for adverse events as well as to the treating physician during sclerotherapy with the pharmacy compounded Polidocanol. Now, in 2000, and I want to say it was 5, at the ACP meeting, we invited Ken McKenna, who is an attorney, a plaintiff's attorney. We invited him to come and talk to us about malpractice suits involving compounded sclerosing agents. He then wrote an article that you can see was published in the Vein magazine. What he told us was that a plaintiff's attorney in a malpractice case involving the use of a compounded sclerosant is going to ask 8 key questions of the defendant physician, and he has to answer all of those questions. First one is, why did you use a non-FDA approved product when one was available? You need to have a very good reason, and it can't be because it's cheaper, and I'll tell you about that a little bit later. You need to answer where and when the agent was compounded, specifically the date and exactly where, which compounded pharmacy. You need to answer what steps did you take specifically to ensure that the compounded agent you used was manufactured in an FDA-registered facility. Did you purchase the agent in bulk? And if so, how is it stored? And what steps do you take to ensure dosage consistency? As you remember from an earlier slide, I said you cannot order a compounded sclerosant in bulk. You have to have a prescription for a particular patient and receive that compounded sclerosant for that particular patient. Number 5, how did you test the compounded agent to ensure that it was safe? And did you test each batch? This puts a lot of responsibility on the physician who is using that compounded agent. Have you ever visited the compounded pharmacy? So do you know where it is? Do you know who in the pharmacy is compounding those sclerosants and what their credentials are and what criteria they're using to test the safety of that compounded sclerosant? Where does the compounding pharmacy acquire its raw materials? And specifically, are they pharmaceutical grade or are they industrial grade? The last one is, do you use compounded agents to increase profit? So if it's cheaper, is that the reason you used it? If that can be the case, and I'll talk about this in another slide in a few minutes, but that becomes a major problem. Because if a physician chooses to use a compounded drug, and a connection can be made between the injury and the drug itself, the physician is liable, period. Informed consent is another issue. You must be able to show that the patient was informed that you're using a compounded drug, and they sign off on that, and that there is a commercial product available, and talk about the benefits of a compounded drug versus a commercial product and the cost difference. Then you can let the patient decide if they want to pay extra for the commercial product as opposed to the compounded drug. The most important qualities that a sclerosant should possess are safety, efficacy, lack of untoward effects in pursuit of durable and repeatable results. So I'm going to present a case with which I was involved briefly. This is a malpractice case. It was filed, I won't tell you where, but it was filed on behalf of a 75-year-old woman who presented to a practice with varicose veins. She had a previous history of breast cancer some 6 years earlier and was on tamoxifen. She was taking thyroid medication and antihypertensives. She did volunteer work for which she stood 12 hours per day. She had a previous history of a rather vague phlebitis. She was a former smoker and she was on horse chestnut extract. She had a bilateral scan which showed bilateral great saphenous vein reflux and then underwent bilateral great saphenous thermal ablation. That had been done in 2011, so this was 2 years earlier. The small saphenous veins were normal at that time. She had all the typical symptoms with the exception of restless leg syndrome and a body mass index of 22.9. These are photos of her initial presentation. So you can see some skin discolorations, significant corona phlebitis, and some other varices in the area, lower leg. A duplex scan showed that the left great saphenous vein was absent, but the right side had reflux, was present, it had reflux over 3 seconds. Small saphenous veins were still normal. So on May 22nd, 2013, the patient underwent a right great saphenous vein laser ablation and bilateral lower extremity sclerotherapy using 35 cc's of 0.6% compounded STS. It was foamed in a 4-to-1 ratio and injected with a 27-gauge butterfly needle. The patient returned to the office 1 week later with bilateral foot and ankle ulcers. She underwent debridement, gel-filled dressings, antibiotics until she was sent to a wound center. These are the images of her at 1 week on the left. You can see the bilateral ulcerations, 2 weeks, and then 7 weeks as the wound center had her mostly healed. And then finally, this is discharge from the wound clinic. So you can see that she cleared fairly well. However, she continued to complain of severe pain in her lower legs. She underwent a neurologic consult which documented peripheral neuropathy. She was treated with gabapentin and had a nice response to it with reduced foot pain and now sleeping better. The physician was sued for malpractice, and the defense attorney called me to ask me to review the case and help in his defense. I have done this a number of times before. When I really got questioning the attorney and the physician, I became aware that the physician thought his product that he used was an FDA product. As a matter of fact, he had been told by the compounding pharmacy that the STS he was receiving was an FDA-approved product. So I took it upon myself to call the same compounding pharmacy, and they told me exactly the same thing. This is FDA-approved. But because of the use of the compounded sclerosant, regretfully, I had to decline assisting the physician's defense. It's not defensible when you have an adverse outcome related to the use of a compounded drug. The physician is liable, period. The defense attorney maybe was not the best defense attorney in the state. And he told me that he was going to go ahead and proceed with the case, hoping that the plaintiff's legal team was not aware of the use of compounded sclerosant and wouldn't bring it up. That's a pretty weak position to go into a case from my standpoint. So my conclusion is when the sclerosant quality, efficacy, and liability are carefully considered, it would behoove physicians to use only an FDA-approved sclerosant. I really think it's a no-brainer. I think we should all strive to avoid disasters when we're treating patients the best way that we can, and that the use of compounded sclerosants may place the patient at risk of injury and may also represent a really significant medical legal burden for the provider. Currently, the only available FDA-approved sclerosants are the brands of Sclera, which is 1% Polidocanol, and Sotradecol, which is sodium tetradecyl sulfate. I would emphasize that no matter what you may be told by a compounding pharmacy, it is simply not possible to obtain an FDA-approved sclerosant from any compounding pharmacy. Why put your patient and you at medical legal risk to save some money? Just doesn't make sense to me. And I want to thank you very much for this attending this presentation. It concludes my portion. If you want to receive credit, please return to the program page and fill out the post-activity questionnaire and webcast evaluation. Again, thank you very much for your attention.